When we talk about cancer care, we usually talk about the medicines, the chemotherapy, the immunotherapy, and targeted treatments. But as an oncology infusion nurse, I can tell you, some of the most important care never comes from the IV pump. I work in an infusion center. I administer high-risk cancer therapies every day. And while medicine is essential, it's not the only thing keeping patients safe. The real work often happens in the space between visits. It happens when patients go home with side effects that don't follow a neat timeline, when labs change days later, when fear shows up at 2 a.m. That's where outcomes are shaped. Modern oncology is complex by design. We deliver highly specialized treatments in short visits, often at moments when patients are overwhelmed, frightened, or still in shock. Information is being given. Doctors and nurses explain carefully, thoughtfully, and with skill. But explanation is not the same as absorption. In cancer care, information has to be repeated, sometimes multiple times, sometimes in different ways. Stress, fear, fatigue, and medication all affect how the brain processes and retains information. So when patients struggle later, it's not because the care team didn't try. It's because a single explanation in a time-limited visit isn't enough. What we often see labeled as non-adherence, anxiety, or poor coping, in reality is an education gap created by timing, overload, and human biology. And closing that gap doesn't mean blaming anyone. It means designing care that allows understanding to unfold over time. Nurses are trained to anticipate risk. We don't just ask, what medication's being ordered? We ask, what could go wrong after this patient leaves? We translate lab values into real life. We turn side effects into decision-making tools. We help patients recognize when to rest and when to call. Clear education isn't reassurance, it's a safety intervention. When patients understand what's normal, they call sooner, and when caregivers know what to watch for, complications are caught earlier. This is how we prevent emergency visits. This is how we keep treatment on track. I've seen patients walk into treatment braced for the worst, and then settle the moment they finally understand what their body is doing. Nothing about the medicine changed, but the care did. Cancer care doesn't end when the infusion does. If we want safer, more humane oncology systems, we have to invest in the care that happens between the medicines. That work is often led by nurses. Not because we administer the drugs, but because we live in the space where education, safety, and humanity intersect. When we value that work, when we design systems that support it, patients don't just survive treatment. They navigate it with clarity, dignity, and trust.